Challenging the cervix. Strategies to overcome the anatomical impediments to hysteroscopy. Analysis of 31,052 office hysteroscopies. Hysteroscopy is currently regarded as the gold standard for the evaluation of the uterine cavity, and in most centers it is performed in an office-based setting. Indeed, office hysteroscopy has shown good correlation of findings compared with inpatient hysteroscopy, while offering distinct advantages in terms of reduced anesthetic risks, enhanced time-cost effectiveness, as well as patients' preference. Data available in the international literature report the success rate of office hysteroscopy as ranging from 90% to 95%. Pain experienced throughout the procedure, as well as the various anatomical impediments to hysteroscopy which challenge the access to the cervical canal, represent the main limiting factors to the widespread use of office hysteroscopy. Among the most relevant anatomical impediments are cervical stenosis, usually defined as cervical scarring of variable degree, and comprising both subjective impression of narrowing and the completely obliterated external and internal cervical ostium. Cervical stenosis can be congenital or acquired. These latter are more common and mainly associated with aging, use of progestogens, nulliparity, curettage, and cervical surgery. The objectives of our article are to report our 18-year experience in 2 hysteroscopy units on 31,052 patients undergoing office hysteroscopy, of whom 32.7%, 10,156 cases, with cervical stenosis. To describe some strategies to overcome cervical stenosis at office hysteroscopy, reducing the rate of failed procedure and inpatient conversion. The hysteroscopic procedures were performed between January 1996 and September 2014 at the University of Bari and University of Naples Federico II. Office hysteroscopies were performed using a 5 mm rigid hysteroscope with a 5 French operating channel and an oval profile until 2002. Or 4 mm hysteroscopes from 2003 to 2014. Saline solution was used as distension medium, which was provided through an electronic system of irrigation aspiration. Neither analgesic nor anesthetic drugs were administered to the patients before, during, or after the procedures. Vaginoscopic approach was used to access the uterine cavity. Operative instruments used were 5 French grasping forceps with teeth, crocodile forceps, 5 French scissors, and 5 French bipolar electrodes. Cervical stenosis were classified on the basis of their localization in stenosis of the external cervical ostium, type 1, combined stenosis of third superior of the cervical channel and internal cervical ostium, type 2, stenosis of the internal cervical ostium, type 3, combined stenosis of external and internal cervical ostia, type 4. Cervical stenosis were overcome by the following strategies used individually or in combination. Adhesiolysis with the tip of the hysteroscope, technique number 1. The 30 degrees angle view gives to the distal tip of the hysteroscope the shape of a wedge, able, combining a gentle insertion together with the rotation of the scope on the endocamera, to perform a mechanical adhesiolysis. This technique is mainly used when the stenosis is more than 3 mm and it is based on filmy adhesions. Adhesiolysis with 5 French grasping forceps with teeth, grasp and rotate technique. Technique number 2. The crocodile forceps is inserted within the fibrous ring with the jaws first closed and then gently opened in order to stretch the fibrotic tissue. This technique usually follows the technique number 1. It is useful when the stenosis is less than or equal to 3 mm, or the technique number 1 shows its limits. Adhesiolysis with 5 French scissors, technique number 3, is used when technique number 2 fails, with the forceps that are not able to stretch and open the thick fibrotic tissue, that reduce the diameter of the orifice. The sharp scissor cuts the fibrotic ring at 3, 6, 9 and 12 o'clock position, and therefore the scope can be inserted as described in technique number 1. Adhesiolysis with 5 French bipolar electrodes, technique number 4. This is an alternative to technique number 3 in terms of instruments used. The technique remains the same. Hysteroscopies were classified as successful or failed according to the following criteria: successful, incomplete, failed. The primary outcome measure was the success rate at overpassing cervical stenosis, including both successful and incomplete hysteroscopies. In our experience, an access to the uterine cavity with a complete evaluation of the whole endometrial surface was possible in 93.9% of cases. The main reasons of the incomplete and failed hysteroscopies are shown in these figures. Cervical stenosis represent the main cause of failed hysteroscopies. Cervical stenosis were identified in 32.7% of all procedures. Type 4 stenosis, that is, combined stenosis of external and internal cervical ostia, represented the most commonly detected one. In relation to patient's age, all the cervical stenosis resulted more frequent in menopausal than fertile women, except for type 1 stenosis, that is, stenosis of the external cervical ostium, which were more frequent in fertile women. Cervical stenosis were managed successfully in 98.5% of cases, with only 1.5% requiring a further ultrasound-guided hysteroscopy under general or loco-regional anesthesia. The technique number 1 resulted the significantly more used strategy to overpass all types of cervical stenosis, followed by technique number 2, number 3, and number 4. In case of combined techniques, the one taken in considerations has been that able to overcome the stenosis. Bipolar electrodes were used more frequently in case of type 1 and type 4 stenosis in comparison with the other types of cervical stenosis. The results deriving from one of the largest series of hysteroscopies have demonstrated that recent technical and technological innovations, together with the increased operator's experience, have made it possible to overcome even severe cervical stenosis at office hysteroscopy, thus significantly reducing the rate of failed procedures and the need for operating room and general anesthesia.